UCSF, conclude with some expert consensus and future directions. All right, so, oh my gosh, can't get this thing to leave my screen. Clearly having some slide issues, but, okay. Hopefully it'll go away eventually. You guys can't see that, that pop up in the middle of my screen?
No.
No, okay. All right, well, it doesn't want to go away. All right, so there is growing evidence for the benefits of specialty palliative care, as you all know, so I won't belabor this. You know that it can improve symptoms, quality of life, increase advanced care planning, etc. However, still not all patients with palliative care needs receive palliative care when and where they need it. So we still have work to do. There's many reasons. None of these are going to be surprises to you, but the lack of availability of outpatient palliative care services, particularly for non-cancer populations, which is a big focus of mine. Lack of knowledge and trust in palliative care by referring clinicians. I know we've made tremendous headway there, but I still think that there's some work to do. And then really everyone's busy, and I don't want to fault my colleagues at all in other specialties. They're doing a million things, monitoring their patient's illness and talking about, disease modifying treatments. There's a lot on their plates. And so it's hard to remember palliative care and take the time, find the time in their short visits to introduce it. And on the part of patients and families as well, they're really busy managing their illness. It's hard to ask for that one extra thing. But collaborations, close working relationships, consistent relationships between palliative care and other specialties have been touted as a solution to help overcome some of these challenges. So just as a very brief aside, in terms of terminology, I might use the word collaboration, by which I mean two specialists, a specialist in palliative care and another specialty working closely together and making an effort to coordinate their care. And that's along the same spectrum as embedded care, where I think of people being co-located. So the palliative care docs joining the oncologists and working side by side, shoulder to shoulder, with or without coordinated visits. And that's on the same spectrum again as integrated systems of care, where there's sort of co-creation of care and proactive screening to make sure every patient with palliative care needs gets it. I'm going to talk about some of each of these types of programs. So hypothesized benefits of working together through such collaborations. When we started, we hoped that this would lead to more consistent referrals to palliative care, operations for bidirectional education, highly coordinated care, improved patient experience, increased advanced care planning and decreased healthcare utilization at the end of life, and improved job satisfaction for clinicians. So I hope to circle back to this and convince you of each of these points by the end of this talk. So a few case studies, mostly from UCSF in breast oncology, colorectal oncology, the ALS clinic, Parkinson's disease, and interstitial lung disease. To start with the breast care clinic, because this was the first of our embedded programs that we tried probably about 10 years ago, starting 10 years ago at UCSF, led by my mentor that I mentioned, Dr. Mike Rabo. Essentially what he did, he designed this program called ABC, Advanced Breast Cancer Program, and he embedded within the breast cancer clinic and saw patients with metastatic breast cancer. He was only there 1 half day per week, and he had a 50% clinical research coordinator who supported the program, and of course had close partnership from the interdisciplinary oncology team. And patients with metastatic breast cancer were referred to him at the discretion of their oncologist. The first palliative care visit was coordinated with an oncology visit, so they'd meet Dr. Rabo at the same time that they were meeting other members or seeing other members of the oncology team, and then he would follow up with them sort of as needed at a frequency that felt appropriate. 20% of his follow-up visits occurred by video. The majority were in person. And they also held monthly case conferences with the oncologists and had weekly meetings with the oncology social workers and a breast onc fellow who was really interested in this collaboration. And what they found in this study that they published was that compared to patients who were co-managed before this embedded ABC program, more patients in ABC were referred to palliative care early, defined as more than 90 days before death. So 100% of the patients who were referred to see him were referred more than 90 days before death, which was compared to 25% before they started this program. So it led to earlier referrals. And he found that the patients followed through this program had less ICU days in the last 30 days of life, and 72% used hospice, which was another goal. They wanted to connect people with hospice appropriately and early. And the patients and oncologists were highly satisfied with the program. So they rated it as 9.2 and 8.5 out of 10, respectively. In terms of feedback from patients, most patients felt that they were referred at the right time in their care, which is when their symptoms were worsening and significantly affecting their quality of life. So an example quote was, "I probably would not have walked into the ABC program. I'm not sure I would have made the effort to go with so many things going on in my schedule every time I come to UCSF. I wouldn't have made the effort to figure it out on my own. I really had no idea how helpful it would be." So that quote kind of speaks to how seeing palliative care as part of the oncology care integrated into the system may help get it to more patients earlier. And oncologists shared that 100% agreed that it provides emphasis for what they've already been working on, provides support that I don't have time to provide myself, and provides specialty expertise that I don't have. That study did not specifically look at the impact on symptoms, but I wanted to share that we separately, around a similar time, analyzed the impact of our outpatient palliative care clinic and the cancer center in terms of its impact on symptoms. And we did see an impact on symptoms. You can see from baseline to first and second follow-up. So it looked like, in the case of at least a few symptoms, that the impact of palliative care is greater for people who have more follow-up visits. And we also separately analyzed our data from our cancer-based palliative care clinic and found that early palliative care led to lower rates of hospitalization, ICU admission, and ED utilization in the last month of life. So the direct costs of inpatient care in the last 6 months of life for people who received early palliative care more than 90 days before death were significantly lower than patients who received late palliative care, while outpatient costs were similar. Another example, not from UCSF, but that I wanted to share with you, was looking at a program where palliative care was embedded at one site within a 3-site private oncology practice. And I thought this was interesting. So the blue line is the practice where they had palliative care embedded and physically located at that site. The magenta and green lines are also clinics in that practice, but they didn't have palliative care embedded physically at that site. And you can see that once they embedded palliative care in 2004, there was this marked uptick in the number of palliative care referrals shown on the y-axis, whereas the other sites where palliative care was not embedded, the referrals sort of crept upward. And they also found that palliative care consultation was associated with reduction in symptom burden by 21% and high provider satisfaction. We went on after the ABC program in the breast care center to look at embedded palliative care for patients with metastatic colorectal cancer. And in this case, we had specialty palliative care embedded in the GI oncology clinic, specifically for patients with metastatic colorectal cancer. So this was a project I led. I was there just 1/2 day a week, and I collaborated with the interdisciplinary oncology team, so the oncologists, the nurses, the social workers, and practice coordinators in oncology. And we actually tried to capture all patients with metastatic colorectal cancer and see them within 90 days of them being diagnosed or establishing care at UCSF. And the palliative care visits were scheduled independently from the oncology visits. So we didn't necessarily coordinate our visits on the same day. We also had weekly 30-minute case conferences with select members of the oncology team. So certain oncologists and oncology fellows, as well as the oncology social worker, joined me to talk about some of our shared cases. And what we found from this experience was that in patients with early metastatic colorectal cancer, symptoms were actually mild. On the ESAS, the symptom scores were 1.85 out of 10 on average, and 78% of these patients reported good or excellent quality of life. So with this low symptom burden and low distress level, we weren't surprised that we weren't able to show a significant impact on those symptoms. But we did show improved prognostic awareness, and advanced care planning documentation was much more consistent. So those who received this early embedded palliative care had 83% had a surrogate decision maker documented, 63 compared to 13% had an advance directive in the EHR, 27 versus 7% had a pulsed in the EHR, and 43% versus 17% elected said that they wanted to limit their life-sustaining interventions. There was a trend towards decreased hospitalization in the last 30 days of life and increased hospice utilization that didn't meet statistical significance. When we talked to patients about the program, some of the themes that came from the qualitative analysis was that the program was responsive, was a welcomed additional resource for advice and guidance, assisted with symptom management, provided empathic care, assisted with care coordination, including during transitions of care. A couple example quotes was, her involvement made the whole process less stressful and scary. Her being a liaison between everyone helped with the whole process. It was a positive thing that I had backup along with the oncologist to make me feel like I had a whole team that was supporting me. And from the clinicians, the oncology clinicians who were involved in this program, they said there's a value to working closely as a team because I just cannot be everything to everyone. This is from an oncologist. And people on the medical oncology team definitely had work offloaded by sharing the symptom management and other sorts of follow-up. That was super helpful. And then probing to think about how we could do this better and what we can learn from this experience, a comment was made that focusing on patients with high palliative care needs rather than a specific disease state probably makes sense. So again, we felt that patients with early metastatic colorectal cancer actually, in some cases, didn't have high palliative care needs. And this program may have been able to be even more impactful if we had screened for people with high needs. This was one of those, in case there's any early faculty out there who are like involved in an initial project and you're having this sinking feeling that like, oh gosh, I didn't do this perfectly. I would have done things differently next time. That was definitely this project for me. I was like, oh, I'm not sure we focused on the right patient population. But yet I learned from it. I went on to be very grateful for the experience. So I hope that could be your experience as well. Another comment, certainly patients who have either symptoms or are actively thinking about goals of care or advanced care planning, those are great patients to get involved early on. Those are the ones who tend to be the most amenable. So certainly important learning here. It was helpful, particularly for patients who had either psychosocial or family complexity. Another program, embedded program that we went on to build next was in the ALS Center. I wanted to share a little about that. We had an interdisciplinary palliative care team. So this was different in that our cancer center palliative care clinic has always been sort of a palliative care provider, so MD or MP, collaborating with the interdisciplinary oncology team. So the oncologists, oncology nurses, oncology social workers in each practice. But on the non-cancer side, in large part because a lot of the non-cancer referring services don't have robust teams, we did build a interdisciplinary palliative care team. So palliative care doctors, nurses, social worker, and spiritual care provider working together. And we embedded this whole interdisciplinary palliative care team within the ALS Center at UCSF, initially 2 days a week, starting back in 2017. And we did a lot of bidirectional shadowing, bidirectional education, and we have an ongoing case conference series that occurs on a quarterly basis now. Referrals came per the neurologist's discretion, so we didn't try to see all patients with ALS, but really trusted the neurologist to refer those who they felt had particularly high palliative care needs to us. And initially, the neurology and palliative care visits were coordinated on the same day. And then what we found is that care model is actually quite exhausting to patients because we had so many providers on each team, and the days would turn into sort of half days at the clinic, and it was too much. So we moved to a system of seeing people on different days, mostly, and palliative care team would see people by telemedicine, and that's worked much better for us. In terms of findings, we found that this was indeed a population with very high needs. So half of the patients seen by the palliative care team were found to have pain. Almost everyone had non-pain symptoms. Psychosocial needs were very common, 80%, spiritual needs and 40%, and advanced care planning needs in almost everyone. And in terms of the intervention provided by the palliative care team, we did address all of these needs quite commonly when they were found, and also provided family caregiver support. So we were able to show an impact on advanced directive completion and post completion. You can see before palliative care compared to after. And people used hospice very commonly, generally for more than 30 days. Also, kind of surprisingly to us, medical aid in dying was a topic that came up very commonly in this patient population. So actually, if 30% of the patients we saw did choose to end their life through medical aid in dying, and this was clearly one of the reasons that the neurologists were commonly referring patients to us, because it's not that 30% of their patients overall end their life through medical aid in dying, but this was a need that they were seeing commonly, and they were referring these patients to us. So yeah, that is what we found. It's been an interesting aspect of this collaboration. Around the same time, Benzie Kluger led a multi-site randomized clinical trial that we participated in which patients with Parkinson's disease or a related condition and high palliative care needs at 3 different academic medical centers were randomized to either integrated neurology with palliative care, and they saw the patient every 3 months and used standardized checklists to sort of make sure that their care was comprehensive and somewhat comparable across sites versus usual care. And what they found is in panel A, this is patients' quality of life. And you can see that it diverged by 6 months, which was the primary endpoint. And then you can see caregiver distress, the Zaret burden index in panel B, and here it didn't diverge by 6 months, but did by 12 months. They also found that palliative care integrated with the Parkinson's care led to improved non-motor symptoms. So those are symptoms like depression, anxiety, fatigue, constipation, and improved motor symptom severity, which was kind of a surprising finding, that these patients co-managed by palliative care also had improved motor symptoms. And secondary analyses also suggested that the benefit was greater for patients with the highest palliative care needs. Also greater for women, interestingly. Don't have a full explanation there. We went on to study patients with interstitial lung disease, and we did a collaboration here. Again, the interdisciplinary palliative care team was embedded within the ILD clinic at UCSF. This was transitioned primarily to seeing patients by telemedicine, all working from our own homes during the COVID-19 pandemic. I'm sure that was no surprise to you. And the referrals came per the pulmonologist's discretion. We found that these patients who were referred were fairly symptomatic, 5.5 out of 10 in terms of shortness of breath and tiredness, 5.3 out of 10 for well-being, also some poor appetite. And in terms of what the palliative care team did, this was actually not a major outcome that we were planning to share, but our reviewers asked for it. So 51% were prescribed opiates for shortness of breath. None had opioids prescribed for shortness of breath at the time that they met palliative care, interestingly. Most of those opiates that were prescribed were low-dose PRN opiates that the patient might not even take on a regular basis, but were prescribed for them to have in case they had an episode of severe shortness of breath, although a few patients were on chronic daily long-acting opiates. And we found, once again, a very significant impact on advanced care planning. In terms of feedback from patients and caregivers, all the patients and caregivers who were interviewed agreed with the statements that they would recommend palliative care to other people with ILD, and that care provided by the palliative care team helped them feel more supported to cope with their illness. And all but one said that the palliative care team provided care that was not otherwise available to me. The other was neutral on that. And further qualitative comments were included that with palliative care, they're looking at a complete package to help you through both the emotional, the physical, all aspects of your disease. So that, I think, is a big difference. Additionally, I think there's a real sensitivity to what the patient needs. There's a high degree of patience and understanding exactly where the patient is at, what they're looking for, and how they can be helpful. The doctor made suggestions about my medicine and helped me overcome bad side effects. This was certainly common. Half of these patients with ILD had IPF, by the way, and were on antifibrotics. And we found that helping patients manage the side effects of those, which can include nausea and diarrhea, as well as fatigue, was one part of the intervention here. And one of the things that I think is particularly good about it is that they recognize the effects of a serious disease like I have, not only on me, but the whole family. So caregiver support was also a big part of the intervention. I also wanted to share that one patient made a comment about how the doctor in palliative care will have one point of view, which may or may not be completely aligned with the other advice we've received. It's not that they're polar opposites, but they just may not be identical. So it becomes a little confusing as to which one to follow. So I think that's wanted to acknowledge, some of the complications that can be introduced by having many providers involved in a patient's care. In terms of feedback from involved clinicians, they shared that they had a high perception of benefit of this collaboration for patients. 9.4 out of 10, they reported high personal satisfaction with the collaboration, and they felt that the overall success of the collaboration was 9 out of 10. All clinicians stated that they would definitely continue the collaboration at UCSF and recommend developing collaborations between ILD and palliative care teams at other health systems. In terms of comments, when we did a focus group of all the clinicians involved, they said, I think it's a good thing for us and them too to see everybody all in one team. Sometimes we get stuck. We're looking at a case a particular way, and just having a different perspective can really make the care more comprehensive and move things forward. And sometimes, this related to patients being evaluated for a lung transplant, for example. There are a lot of family and caregiver dynamics that you uncover that play a huge role in the decisions they're making or how they feel. And finally, he was having significant changes in his function, his role, and his relationships as a result of his illness. He had a lot of questions about how to navigate these sorts of things. In terms of impact on clinicians, they commented, it's a huge stress relief to know that you're there. There are a number of things that we're trying to talk about in visits, and sometimes people have really advanced disease, so we know we have a lot to cover. Knowing there's another team that's going to follow up on advanced care planning in particular has been really nice. And I feel like I've learned a tremendous amount from you guys, and I really, really appreciate it. It's always exciting as an old nurse to learn new things. But when we talked about, next steps and the way forward and what can we learn to inform future collaborations, the clinicians commented that picking the right patient population, focusing on a patient population that has substantial palliative care needs, is key to demonstrate to everyone, including the patients, that there's a benefit from this. So similar learning that we learned from the colorectal cancer project, for example. And I think that the particular personalities involved make a really big difference in whether a collaboration succeeds or doesn't. There has to be real interest on both sides. This has certainly been another central learning for us. And we do see some providers refer a lot and other providers refer less. A routine screening process might ensure that we reach the patients who would benefit most from palliative care. A couple more
Sorry to interrupt, but there's a question in the chat related to this last section you were talking about. Nora is wondering if you know what percentage of the patients with ILD referred to palliative care were also being evaluated for lung transplant.
I don't have a percentage, but I might say half, roughly half. I think some people aren't yet at a place where they need a lung transplant. I certainly have a number of those patients in my panel. Other patients are unlikely to be a lung transplant candidate. Either they've been outright declined or they're of advanced age or not interested in a lung transplant. So it's certainly common. And we're pleased that being evaluated for lung transplant or being on that path did not exclude them from being referred to us. At least by some providers. But I think in the pulmonary clinic, maybe more than some of our other clinics where we've done these embedded programs, there was heterogeneity in the providers in terms of their comfort referring to palliative care. And some of that had to do with opioids. Some of the pulmonologists were a little terrified that we would start their patients on opioids. We tried to work all that out, understand their unique feelings around this and make sure to communicate with them before we started opioids. But I think that honestly has been a bit of a particular issue in this collaboration. So one from the emergency department at Mass General from the COVID pandemic, I just wanted to share briefly. They embedded a palliative care physician in the ED from 9 a.m. to 7 p.m., 7 days a week during the early part of the pandemic. And the emergency department providers reported that having this palliative care provider there freed them up to perform other tasks. They felt more supported. It changed the patient management and care trajectory in some cases. So not everyone agreed with that, but 67% did, and improved their primary palliative care skills and competence and education about goal concordant care. You can see that most providers felt it was very valuable. 64% with the others feeling it was valuable. And qualitative comments from clinicians in this case was that their experience allowed us to provide care within the truest direction and compliance of patients' goals of care, which sometimes I feel can be lost in the rush and uncertainties of an emergency room. And having gone from feeling incredibly well supported at the study site where they had embedded palliative care to switching back to the other hospital where this provider worked where they didn't have that, I feel as though I'm missing a hand. And finally, there was a very large study done of 1,100 physicians from 42 countries. They completed a survey. These are all medical oncologists, and the medical oncologists with access to on-site palliative care reported significantly higher overall job satisfaction. Also, through this study, they found that the oncologists with the lowest job satisfaction were less likely to discuss prognosis. Maybe they were burnt out, just didn't feel like they could go there, and they didn't. So that was interesting. So I want to really conclude or get to this discussion of what conclusions can we draw from all of this work that I kind of run you through that we've been engaging in over the past 9 or so years. We did pull together a panel of everyone at UCSF who's been involved in an embedded palliative care program to try to think about what can we all learn together from this experience. And we really are convinced that embedded palliative care programs or working more consistently with a particular referring specialty can lead to more consistent earlier referrals to palliative care. It does present really important opportunities for bidirectional education, can lead to highly coordinated care, improved patient experience, increased advanced care planning and decreased healthcare utilization at the end of life, and improved job satisfaction for clinicians. And additionally, we found that there was an opportunity for research and leadership for a lot of our faculty in these particular disease areas that they perceived as an added benefit. In doing this work, some things that we think are really important to consider is the nature and intensity of the collaboration. So I mentioned there's that sort of spectrum from a collaboration. You're just say, hey, refer me your cases, refer me your patients with pulmonary hypertension. That's a population I'm interested in. I'm happy to see your patients. I'll route you my notes and communicate with you that way. That's good. That's pretty easy to set up, low barrier to entry. But then farther along the spectrum, you can actually embed, share space with the other clinicians, more opportunities for sort of informal communication. You might attend some of their meetings, might start a case conference series so you can discuss shared cases. And then further along the spectrum, not something I've talked about a lot yet, but I will in a moment, is this idea of sort of co-creating care together and integrating screening processes to make sure all patients with palliative care needs are seen. And I think anywhere on the spectrum is okay. It's good. I think it's just important to think about it up front. Like, what bandwidth do we have? And what interests do we have here? What are the needs of this patient population? And sort of design your program accordingly. Also, very key learning, choose the patient population carefully. This is either going to be an impactful program or it's not, essentially based on what patient population you choose. And in particular, if they have high palliative care needs, it's going to be much easier to show some early wins. So I think it's easier to convince patients with high palliative care needs to come to the visits, easier to convince them of the impact, and the same is true for the clinicians involved. I think when starting a collaboration, it's really important to assess the needs of the referring team. What's bringing them to the table? What's leading them to be interested in this? Is it that they're trying to affect some quality metric that's really important to them or important to the institution? Or is it that they've got this pain point? Certain patients are just constantly messaging them about their symptoms or about their caregiver burnout, whatever it is. What are the pain points that they're experiencing? What are they hoping we can impact? Really understanding their motivations are key. Then you can make your plans both for the service that you're delivering and the outcomes that you're going to track in order to, try to make the difference that matters to them and demonstrate that. Also, it's important to consider your own team's bandwidth. So, there's probably innumerable collaborations that we could be running at UCSF, and we've had to be a little cautious about just, when are we ready to take on another collaboration? What are we interested in? Is there a particular population, it's a particular interest to a new faculty member? Really thinking about that. Don't take it on, don't do this work if there's no bandwidth to do it. Just wait. It's better to wait than to take it on and be too stretched thin to be able to do it right. And to be honest, we've often hired to meet these needs. So let's say the gyn-onc clinic, as a real life example, has been eager to work with us and they want to have a provider embedded in their clinic. If we don't have a provider who has a particular interest in that or has the time to take that on, we just wait. We don't start the collaboration. We try to hire into that when we're talking to new faculty who are interviewing. We say this is a particular collaboration that is of great interest, and assess their interests, because that has worked well when people come into their faculty role with a particular collaboration in mind. The champions are key. So both on the palliative care side and on the other referring team side, who those personalities are, whether they're true believers in palliative care, whether they're, responsive and, dedicated to this project, makes a big difference, and whether they have the ear of the rest of their group. So I think that champions are essential. And yet we also talked in this sort of expert consensus group about how if a program is running completely on the shoulders of one champion, that's a problem too, because maybe that person goes out on parental leave or they leave, something else happens. We don't want the whole project to crumble. So there has to be a really strong champion, but there also has to be a certain amount of buy-in from a much broader group. Invest in the relationships and garner trust. So up front, it's really worth the time to get to know each other, both through that conversation to assess the needs of the referring team, understand their motivations. That's sort of where it starts. But also bidirectional shadowing, even a half day of that, so that we shadow in the ALS clinic, they shadow us, can go a long way towards us understanding each other's practice, really having a more tangible sense of what it is that we do in palliative care for this patient population, so that the referring providers can do a better job describing that and selling palliative care to patients. It also goes a long way to garnering trust. And so I think co-locating can really be helpful in this regard, even though honestly, we're doing a lot less of that since our patients and families have learned how well video visits work and are preferring that in most cases. Do your homework. So it's also really important for us in palliative care to really understand the disease that of the patient population we're serving. So really knowing a little bit about interstitial lung disease is critical. Understanding those antifibrotics and what are their likelihood of benefit, what are their side effects, really allows us to provide a higher quality and more well-coordinated care. So you can learn from shadowing, you can learn from attending their conferences, you can learn from reviewing some of their major studies. And often we invite a member of their specialty to talk to our palliative care team and provide us a really nice foundational lecture. I think doing some of that work is very much worthwhile. I don't think it's good enough, at least in the outpatient setting where we're getting involved much earlier and farther upstream, to just provide sort of homogeneous palliative care to all patient populations. I think you really have to know the underlying disease state, their treatments and their side effects in order to do this best. Also, from the start, it's important to set expectations, including about how you're going to divide tasks between the two teams. So in cirrhosis, for example, I didn't show you this study, but we've had to be clear about when should patients call the hepatology team? When should they call palliative care? Which team is managing the diuretics? It's been a disease area where this has been a little bit harder to sort out than some others. Who's managing the diuretics? Who's managing the lactulose? Is it okay for palliative care to give recommendations or make prescriptions in those areas, or do we need to loop in the hepatology team? And around opioids and other secure scripts, how does the referring team feel about this? Are you in palliative care going to take on all of the opioid prescribing or not? And pragmatic data collection from the beginning is really important. I mentioned pragmatic because we realize that data collection is a lot of work, and analyzing data can be a lot of work too. So we've really tried to be very, not collect data just because it would be interesting, but really make sure we have a purpose for every bit of data that we bother to collect and analyze. But that being said, knowing how many patients from this disease area you see, why they're being referred, what you in palliative care are doing for them, and what outcomes result, at least a few core foundational outcomes that really matter to everyone involved, is very important to kind of get everyone's buy-in. And as an aside, since you're an academic institution as we are, I've found that as an example, when I've come to the oncologists and said, we'd like to try seeing all of your patients with metastatic colorectal cancer from the time of diagnosis, they're much more motivated to give that a shot if we're collecting some data and we're going to see if this has the desired impact or not. The idea of contributing to research really brings the oncologist to the table in a way that, if we weren't doing that study together, they might be less committed, less interested, or perhaps in some cases, even a bit skeptical. And funding the work has been an ongoing challenge for us. So if you're feeling that pain, we definitely are too. We haven't quite figured this one out. And I'd love your thoughts about how to fund this ongoing work. We've been lucky to have some funding from generous family foundations, mostly in the Bay Area, to give a little bit of money to cover the time of people who are starting these collaborations. But after the start, it's hard to find dedicated funding to support the ongoing work required. So we've tried to be sort of, again, pragmatic or parsimonious in how much we offer, realizing we can cover the time we spend seeing patients with RVU-based billing, but we can't commit to a whole lot of other outside meetings. We'll go to some, maybe one meeting a month is reasonable. We can all find that time, but we can't commit to coming to your interdisciplinary team meeting every week because that's uncompensated time that is hard to sustain for a long period of time, unless the other specialty is able to provide a little bit of protected time for our providers. And finally, ongoing maintenance is really needed. We've had a couple collaborations that have been great. We've gotten them off the ground. They seem like a great success. But if we don't continue to tend to them, at least through something like a quarterly case conference, series, they start to wither on the vine. People get distracted and move on. So some degree of ongoing maintenance is needed to keep these really vital. And really, if there was one thing I was going to convey, I think it would be this Venn diagram, that it's important to look for that overlap in the Venn diagram between where patients have great needs, the primary team has great needs, and your palliative care group has great interest. That's going to lead to a good, successful collaboration. And so then the final section of this talk, I just wanted to talk about kind of where we're heading next. As you can hear, we're doing a lot of these collaborations. We're excited about them, that we think that they're impactful, but a next frontier for us is to sort of address these 4 key questions that were laid out by David Hui. He really said, we as a field in palliative care, now that we've reached our current level of maturity, we need to think about who is it who really needs specialty palliative care? What's the right time for that care? What's the right service model, and how much palliative care is needed and beneficial? We really need to use marshal our resources wisely. So to kind of address that, we've launched this program called Care Plus. It's a system to proactively, consistently, equitably, and efficiently screen for and address palliative care needs of a population. So we started this 3 years ago, and we initially focused on Medicare patients in primary care. We designed an electronic screen where, based on ICD-10 codes and utilization patterns, we identify these Medicare patients with serious illness. And then we have a grant-funded care navigator who calls these patients and administers a telephone survey to assess their palliative care needs in 5 domains: their physical symptoms, their emotional distress, their practical needs, their advanced care planning needs. And the care navigator also asks for permission to screen family caregivers for their needs. And based on the needs that are identified, the care navigator routes a brief telephone encounter to the primary care doctor outlining these needs, and offers tailored palliative care services based on the needs that are identified. So if patients have a lot of physical symptoms, the care navigator introduces the concept of outpatient palliative care and sees if patients are interested. If so, she pens a palliative care referral and attaches that to the note that she routes to the PCP. Or if the patient has a lot of emotional distress, she offers support groups. We have these for a variety of different, populations at UCSF. If patients are interested in that, she provides information about those support groups, also lets the primary care doctor know that she did that. Or if patients have a lot of practical needs, she tries to, sort of drill down a little bit to understand these needs and make sure that the patient's connected to a social worker to help them. If they have advanced care planning needs and they're interested in engaging in advanced care planning, she offers either the Prepare for Your Care interactive ACP website or our advanced care planning workshops, and lets the primary care doctor know so they can follow up. And similarly, if family caregivers have a lot of needs, depending on what those needs are, she offers services. So we're really testing this system to see how it works. And the care navigator, I should mention, also follows up after these initial calls to make sure that the needs are adequately addressed through the services that she offered. We did a stepped wedge trial and looking at this for the first 3 phases of this intervention. And what we found was that, going back. All right. Well, I've got a big box in the middle of this. Sorry about that. But the physical symptoms were very frequent, and symptoms impacting quality of life or function, also common, 64%. 28% had severe symptoms. And so the care navigator offered palliative care to about 33% of people. It wasn't accepted by everybody, but 17% of people did accept the palliative care referral. If I didn't have a giant box in the middle of my slide, it would show that the emotional distress was also very common in this patient population, and that some, but not all, patients accepted the supportive care, the supportive services we offered for that. Practical needs were found in 38% of people. A social work consult was accepted by some of those, and advanced care planning needs were also found commonly. and services were accepted. And of interest, we found that there are no significant difference in the rate of palliative care needs by racial, ethnic, or linguistic group, which was one thing we were interested in, because again, one of the goals here was to try to consistently and equitably identify and address palliative care needs. And there were also no significant differences in the rate that services were offered to or accepted by patients, except the support groups, which were more commonly accepted by English speakers as they were conducted in English. We found that with this program, there was a significant impact on advanced care planning, much more common during the intervention phase compared to the control phase. And we found that patients' quality of life was preserved during the intervention phase and decreased during the control phase. We, as a next step, are trying this in gynecologic oncology. You might remember the first stage, we tried this in primary care. We hypothesized that by doing this in gyn-onc, perhaps there would be even more common or even more severe palliative care needs. We also used a model of delivering the survey through electronically, sent them through the secure patient portal instead of having the care navigator call in order to try to come up with a more efficient solution. And in fact, this has been the case, that this has been a much more efficient way to screen patients. The survey is only completed by about a half of patients, but honestly, that's not that different than the response rate we got via telephone. And the frequency of needs has been high. So I want to stop there to leave plenty of time for questions and conversation. I'd love to hear about your experiences. But first, I just briefly wanted to acknowledge the many, many people who have been involved in all these different collaborations at UCSF and who've been really important to this work. Thank you.
Thanks so much for that engaging presentation. It's really impressive to see the scope of work you've done across so many different clinics and populations and different models that you've tried. I really enjoyed it. We definitely have time for questions. I see a hand, Sarah.
I was just clapping.
Oh, you were clapping. I'm sorry.
That's very kind.
The wrong kind of hand.
I guess I mentioned that we've done this in the inpatient setting as well. So I just wanted to briefly acknowledge that we've done this with the cardiology service on the inpatient side, where we joined their rounds at a certain frequency, and we, have collaborated very closely and intentionally with them, and attended their, LVAD and transplant meetings, whatnot. We've also done this in the ICU on the inpatient setting, and most recently, we've been doing this with malignant hematology, so the leukemia and lymphoma services. But yeah, I see Jill has a hand up.
Hi, I'm Jill Fenner. I'm a cardiologist at UW Montlake. I study and take care of adults with congenital heart disease. So it's really great to hear about your work. I've been thinking a lot about population recently too, because in my own work, I've discovered that it turns out that it's great if we can get our relatively plateau stable outpatients to think about their futures, but they don't really have a ton of palliative care needs in a way that an intensive intervention or a lot of attention is often what they want, or meaning they don't want that. And so I was wondering, how have you kind of, in narrowing down what is the appropriate patient population to either focus on clinically or with research, how have you gotten the buy-in from others in, say, the cardiology division to put resources toward a small number of patients? Because once you have money for research, that's a lot easier. But until you do, just demonstrating need and really trying to articulate that, I've found a challenge.
Yeah, absolutely. Jill, not directly in response to that question, but a couple things I wanted to mention when you're based on what you said is, so there's some patient populations that maybe don't need the whole enchilada, like the whole outpatient specialty palliative care. Perhaps, at least that's something that we're exploring through this Care Plus project that I described last. We're wondering, are there some palliative care needs that can be met through more tailored palliative care interventions, short of a specialty palliative care consult? And I didn't say it explicitly, but in Care Plus, the majority of the needs identified were met through interventions other than a specialty palliative care referral. So these sort of tiered palliative care interventions. And I wonder about whether some of your patients might benefit from an advanced care planning workshop. And that's an example of an intervention we've developed that can help meet some palliative care needs. And in dementia, I didn't mention this work, but in our collaboration with the dementia group, we've developed group advanced care planning visits for patients with early dementia and their family caregivers. And we found that, early in dementia, like, I don't know if they need specialty palliative care. And then it kind of creates this like sticky wicket, because once you meet them, are you gonna have to follow them for the rest of time? It could be 10 years, or like, how are you gonna say goodbye and not continue to follow them? It's sort of a danger for us. So we have this different model where we're doing early advanced care planning conversations, group visits, build for patients with early dementia and their family caregivers. So maybe that could work for the congenital heart disease population. I don't know if that's one of the needs is advanced care planning. Another thing I would say in response to your comments is that, yeah, we have had some trouble with our cardiologists. It's been interesting, that I don't have a great heart failure collaboration study to share for you today. And yeah, I guess it's because their symptoms seem to be intermittent. It's like they're very sick when they're in the hospital, but then when they get referred to us and we see them in the outpatient setting, they're mostly feeling fine because they've been diuresed. They somehow don't realize that their illness is life-threatening, even though it's called heart failure. And there hasn't been as much like receptivity to palliative care. So I don't know, that's just been our interesting local experience that's been a little bit disappointing. We're not done trying to figure out how to serve that population, but it has been slower to take off than many of our other groups. Like the ALS clinic, they have this robust understanding that their illness is terminal and their symptoms are daily and so profound, and the caregiver needs are crushing. And so it's really easy to convince the ALS team and their patients and families that they need palliative care, but that hasn't been the case as much for us in heart failure. And I could imagine that being particularly challenging in congenital heart disease. So yeah, and yet I think if there was a strong champion on either side, one champion in congenital heart disease and one champion in palliative care who's really interested in this patient population, you probably could design a really nice collaboration and trust could be built. And, you can start with like the low-hanging fruit. Maybe it's around supporting people, who are dealing with progressive debility and a life-threatening illness as a place to start. And you might end up doing a lot more advanced care planning and other things along the way. So I think that there really could be a collaboration built if there's strong champions on both sides. In terms of funding it, there's the challenge. Yeah, maybe you could get a little bit of, seed funding from a foundation because it's innovative, and you could say that you're going to study this and learn from it. And so that can be a really nice option for a few years. I don't know if they would provide ongoing funding, to continue the work, but that's why usually we've sort of had these more robust collaborations that get whittled down to their kind of most sustainable common denominator by the time the funding ends, so that we can continue it through these quarterly case conferences, for example, without investing a whole lot of uncompensated time ongoing. Just a few thoughts.
We're getting close to time. I'm going to alert people. Shanitra is putting a link in the chat for an evaluation that we would love if everyone who's attending would take a moment to fill out. And then, Kara, there are 3 other questions or comments too that are aligned. Christina mentions that this is spot on for the experience their outpatient palliative care clinic has had as well, that they have many lateral department champions and even one level up in management, but it gets sticky after that, especially for what is not typically a high RVU generating department. Curious, how do you see getting buy-in from those who approve additional staff to expand the department? And then Dan Lamb has an aligned talk there, or comment there, saying he notices that the embedded models have 0.1 dedicated FTE. Curious how you see embedded outpatient palliative care translating into the community setting.
Yeah, absolutely. So one thing just to clarify for Dan or others, when I wrote on there that there was like a 0.1 FTE physician. That was them, physician spending 1/2 day a week in the clinic, but they didn't have funding to cover that 0.1. That funding was provided by the RVUs they generated through seeing patients. And generally, if we see 4 patients per half day, we can cover physician salaries through RVU-based billing. So we've been clear with referring providers, like, in order to pay our salaries, we need to see a minimum of 4 patients per half day. So do you have the kind of volume to fill our schedules? And if they don't, we're happy to see their patients intermixed amongst other patients. That's fine. We have plenty of other patients to see, but we really can't spend 1/2 day a week just sort of supporting them and answering questions if it's not leading to RVUs, because we unless we have dedicated funding, which we rarely have had. But figuring out how to cover the nurse, social worker, and spiritual care providers to expand our interdisciplinary palliative care teams has been a challenge, because that's not covered by our RVU-based billing. Those have been investments made by the health system. And I'm sure you guys have thoughts of lots of ways of how to convince your health system of the value of what you do. But certainly we bring back some of this data to them. We've done other analyses, which I didn't show, that showed that patients followed in outpatient palliative care have a reduction in inpatient utilization. So 30% reduction in hospitalizations and hospital days after we meet them compared to before we meet them. So, some of these analyses have been helpful, but it's an ongoing struggle for us. Feels very real and close to home.
And then I appreciate we're really at time, so people can feel free to go. But one last great question from Lisa, which is wondering if you could speak to how primary palliative care practices have been influenced by this work at UCSF.
Yeah.
The clinics you've embedded to.
Yeah, it certainly happened in pockets. Like, there are certain people who I feel confident we've greatly impacted their practice, and they've commented on that when we've done these focus groups at the ends of our collaboration. So that's been wonderful. I can't say we've impacted everyone in GI oncology, but I think even if you can impact a few people, and maybe a few of the fellows or the social workers who you're meeting with more frequently, that can over time, lead to progressive practice change. So I think that that's a huge benefit. A little harder to measure, which is, why we haven't done as good of a job measuring it outside the qualitative comments. But I think it is a real benefit. And we've learned a ton in the process. Like, there's no way I would know as much about ALS or interstitial lung disease if I hadn't been involved in these collaborations. So really benefits us as well.
Great. I think we should wrap up there because we're past the top of the hour, but thank you so much for joining us. This was really an engaging and interesting presentation. So we're delighted you were with us this morning.
Thank you so much. My pleasure. Happy to have conversations with anyone who's doing this work. We can share ideas. I would love to learn from all of you.
Great. Thanks, everyone. Bye-bye.
Bye-bye.